Namaskar. We all have managed so many COVID-19 patients successfully in last 1.5 years. And these patients at times would come for other concerns, other diseases, and will land up for various surgical procedures or requiring ward admissions or requiring ICU care. Now, we all know that the COVID-19 has an implication on the patient in variable formats. We have seen to start with the respiratory issues, but subsequently many organ systems were involved. Many of these patients have survived. Most of these patients are in fact survived. But yes, there would be some impact on the system, on the body, and not only short term, but now it is being seen that the long-term impact of the COVID-19 is also there. So in case if these patients come for any elective surgical procedures, what all we need to take concern, what are the things that needs to be taken care of? We need to assess these patients and what would be its implication. We will discuss in last couple of minutes or so. I bring greetings from my institute. I work at Cancer Center of All India Institute of Medical Sciences. Now this COVID-19 for almost approximately 2 years now, it has caused a lot of changes across the world. The medical science has emerged a lot. Many things has come into picture. And many of the things, newer things, has been added because of this COVID-19. Still, we are learning a lot. Still, new things are coming up. In coming time, probably many more things will come up. But this whole has brought a lot of challenges for anesthesiologists and even critical care specialists, especially when these patients are coming for any intervention, maybe from the surgical intervention, maybe for the diagnostic modalities requiring sedation that is outside the operating room, or at times if they are after some intervention, they require high dependency unit care or critical care unit care. There are many, many challenges that we need to look for. These changes are not related to just because reinfections is also being seen. So how and when to assess the COVID status with regards to immunity, with regards to the reinfection and so on and so forth. When does the body physiology returns to normal? As we know, the COVID has an impact on the whole body. It has impacted a lot into the different organ systems of the body. So it becomes very, very essential to understand that the change in the physiology that has happened because of COVID, how much time will it take to return back to normal? And that is what needs to be understood by looking for the various available evidence that we have. What long-term changes will revert back, and which are those changes may not be returning back, but probably they will leave some long-term impact. And at what point of time this needs to be operated. We also need to look for that apart from our conventional PAC, what extra things from the assessment point of view, from the clinical examination point of view, from the testing point of view, including imaging, what other things needs to be incorporated into our PC that would affect the perioperative outcome. So what to do and what not to do also needs to be like, maybe at times we may not, maybe overemphasizing the things, doing over investigations that again can lead to concerns, but under investigations can miss something and again become challenge. So overall, these are the challenges for anesthesiologists in coming time when everybody is working to his fullest for various surgical interventions and even outside the operating room procedures. So definitely there is no confusion that the perioperative management of the surgery would be challenging in this COVID-19 era. Patients with COVID-19 status with some sequelae, they will pose more challenge. Now, when we see evidence, as in the evidence-based medicine practice, many of the challenges or concerns that I was just mentioning, some of these can be replied as we have some data from the evidence. Some may not have direct data, but they have been extrapolated and probably appears to be unacceptable. But still many things, because it's not long-term sequelae we have seen it, it's just around 2 years or so, less than 2 years in India. We are still many unanswered queries and questions that needs to be answered. And probably more data, more analysis, more meta-analysis will come in near future that will give us answer to many of the queries, many of the challenges, many of the concerns that we have just mentioned. And this is what even the WHO mentioned, that more research is needed to examine the long-term consequences of COVID-19. This is overall. But if they are posted for surgical intervention, probably the interaction of the COVID-19 sequelae and its implications on the perioperative care again needs to be more researched. We know that COVID-19 resulted in prolonged illness for all age groups, even without having any chronic medical conditions. But we need to have a long follow-up studies, maybe multi-year studies, that will give us a fair idea that what actually is the long-term impact and what actually is long-term. Whether we say 6 months, 1 year, 2 years, 5 years, we don't know. Why these symptoms are persisting? Why some of the symptoms are still persisting? How much time it will take to recover from these symptoms, and whether these symptoms will come back to normalcy, we do not know. The changes that has happened, pathological changes that has happened, how they are going to affect the patient overall, and how they are affecting the other organs of the body also needs to be worked out. The clinical course and likelihood of full recovery, implication of long-term health effects on return to work, because we say a patient and the person is socially accepted, socially concerned. So unless he returns to work, that is what we look for. That is what the quality of life is. That is what the outcome of any of the intervention is. This also needs to be looked for. And protective measures continue to be important in preventing COVID-19. Probably the third wave or subsequent smaller waves may arise. Still, we have to follow some of the norms which will be protective to us. As it becomes very, very important not just to understand what is happening in COVID-19 sequelae, but also we should be contributing towards more of the research, sharing our experiences, so that some conclusive, meaningful messages can be taken from those studies which are related to the COVID-19 sequelae and the perioperative outcome impact. We know this is very conventional timeline of the COVID-19 disease, starting from the incubation period with the onset of symptoms, the symptomatic disease, and then probably some pulmonary phase, hyperinflammatory phase, patient recovers, cytokine storm, multi-organ involvement, and so on and so forth. But having said that, what I just mentioned, that what we are looking for is the recovery, that is the physiological normalcy. I'm not just saying that the patient is pathological recover, is COVID-19 now, but what we're looking for, the sequelae, the recovery from the sequelae. Probably we'll put in a more term, physiological normalcy, that what you are looking for. And that timeline, we do not know exactly. We need to have more data. We cannot say 3 months is okay, 6 months is okay, 9 months is okay. That is still difficult to say. And probably in coming time, with more patients with long-term follow-up, we'll be able to take this timeline, that how much is the duration or the period of a patient after COVID-19 is physiological normal. And thus, this probably would have impact and will help us to look for the optimal timing of elective surgeries after COVID-19. The recommendations regarding the definition of sufficient recovery from the physiological changes from the SARS-CoV-2 virus cannot be made at this time. We do not have much data. We do not have evidence for it. But however, the evaluation should include in addition an assessment of patient's exercise capacity. Basically, the patient's overall physiological status needs to be understood. And if you see this, one of the guidelines by a professional body where they talk about the suggested wait times for the from the COVID-19 diagnosis to the planned surgery, they propose at 4 weeks for an asymptomatic patient or recovery from only mild or non-respiratory symptoms, 6 weeks for symptomatic patients who have symptoms like cough or dyspnea, who do not require hospitalization, 8 to 10 weeks for symptomatic patient who is diabetic, immunocompromised, or hospitalized, and 12 weeks for a patient who was admitted in an intensive care unit due to COVID-19 infection. Now, these are very, based on possibly the recovery of the various organ systems involved. And this is basically a physiological recovery. But looking for the evidence which are coming about the long-term sequelae, whether the patient will be absolutely normal after getting a severe COVID-19 infection in 12 weeks, do not know. This means we need to assess the patient. Probably we are putting this is a generic way of giving a guidance for the timing of the surgery. But probably this will again needs to be individualized based on the assessment of that particular patient, and to look for at what type of organ involvement was there at the time of COVID-19 diagnosis, and what all pathological changes happened in the body at that time, and probably what is the recovering profile of this patient. That needs to be understood to take a decision that what will be the optimum time. And again, it will depend upon what type of surgical procedures. The major surgical procedures will require a longer time for the patient to get normal, because there will be a lot of concerns after during a major surgical procedure like thoracotomies, the pneumonectomies, or various cytoreductive surgeries, where you want the patient should be having a good physiological reserves. So that time for the recovery of those physiological reserves as compared to the pre-COVID-19 and that particular patient, we do not know exact time, but yes, we need to clinically assess them so that we can see that these patients appears to be quite optimal. Those who have recovered from COVID-19 remain vulnerable to long-term effects, which increases morbidity and heightens the mortality risk, especially with long surgical procedures like cancer surgeries, like cardiac surgeries, like thoracic surgeries, pneumonectomies, and so on and so forth. And hence, this requires proper, comprehensive, thorough assessment of the symptoms as well as symptomatology for COVID-19. Now we know that to start with, probably it was a respiratory disease, but if you see the manifestation of these patients with COVID-19, the sequelae will be based on the presentation of the COVID-19 at the time of diagnosis, and they could be affecting majority of organs. Neurologic, we have seen headaches, dizziness, encephalopathies, myalgias, anosmia, and even stroke. The renal condition, we have seen the acute kidney injuries leading to proteinurias, even hematurias. The patients had hepatic concerns, including the liver dysfunction with elevated aminotransferases, elevated bilirubin. The gastrointestinal issues like diarrhea, nausea, vomiting, abdominal pain, and anorexias. The thromboembolic phenomena, they are prothrombotic phase. The DVTs can happen leading to pulmonary embolism. Even if they require intensive therapy, the chances of catheter-related thrombosis could be there. They have impact on the cardiovascular system. These patients could manifest myocardial injuries, Takotsubo cardiomyopathy, various types of arrhythmias, even MI and core pulmonary. They could have endocrine issues leading to diabetic picture or worsening of diabetes in a patient who had diabetes. Even the dermatological changes can happen, and that's why sometimes during the surgical procedures, long surgical procedures, the issue from a surgeon's point of view. And the study which has reported that many of these symptoms will persist for variable duration, and most commonly would be even the respiratory issues like dyspnea. The fatigue is one of the important issue, and now we know that fatigue is one of the important predictor for the perioperative outcome. The post-exertional malaise, the brain fog or cognitive impairment, the persistent cough, persistent chest pain, headache, palpitations, arthralgia, myalgia, paresthesias, abdominal pain, diarrhea, insomnia, fever, lightheadedness, impaired daily functions and mobility, pain, rash, mood changes, anosmia or dysgeusia, and even the menstrual cycle irregularities. So these are the symptoms which have been reported to be persisting for variable duration, long duration, and the presence of these symptoms will be of concern and hence requires not only assessment, but probably requires optimization so that these can be taken care in the perioperative period. So this means we need to assess for the whole systems, including not only respiratory, but we need to look for gastrointestinal, the hepatobiliary, the peripheral nervous system, the central nervous system, the cardiovascular system, the ENT, and the eye examination. So all those systems need to be assessed in these patients, looking for the long-term sequelae, the recovery profile, and the present status, which could be quite variable. We do not know exactly which patients will manifest with symptoms. We do not know long-term effects will be manifested for how much duration. So this all mandates that we need to have a thorough assessment with specific focus to those related concerns for the perioperative care when they are posted for any surgical interventions or they are for any diagnostic procedure outside the operating room. Now, this is an interesting study where they have looked for the long COVID or the post-acute sequelae for COVID-19. And they have looked for various biological factors that contribute to the persistent symptoms. And again, as I mentioned here, they have mentioned the fatigue is one of the commonest symptoms, even including the brain fog and the malaise, which has been seen in these patients. And now we know that after the major surgical procedures, presence of malaise, presence of brain fog can have implications if we are looking for early mobilization of these patients, early ambulation, which is needed for the day. Even the brain fog can have issues because we do not know whether it has any association with conditions like delirium, late awakening, the impact of using opiates in the perioperative period. How would they interact with these persistent symptoms? They are still the research needs to be researched and the data needs to become up. But yes, we are very sure that so these are the features that would have impact on the perioperative outcome, and hence not only its assessment and documentation, but also how can we try to decrease the impact of these residual symptoms on the patient's perioperative management also needs to be taken care of. Other important aspect is we know that the COVID-19 has caused a lot of immune modulation, even immune suppression. And this has been impacted by steroid supplementation, which has been used to variable dosages. And this immunomodulatory or immunosuppression affect the recovery profile, though it is considered that they will recover over time. And the immunity system also persists into the body, which can be at times protective. But what this immunomodulation, what are the protective levels, what are the chances of free infection, they all need to be looked for when we are managing these patients in the perioperative period. We are not in a phase to say that we are totally COVID-free and those who have been infected once will have long-term immunity. We also don't know that what will be the duration of immunity which has been captured by COVID vaccination. So this means we need to look for the assessment of these patients, to look for the immune status of this patient, which could have been altered by various regions. And we also need to be looking into the matter that even if they are infected, even if they're immunized, what is the exact duration of protective levels of serum, whether we need to investigate them, look for the antibodies, because we do not have specific antibody measurement tools that can definitely say that this patient is totally immune to COVID-19 or not, we do not know. And hence the risk of reinfection, we still are a little worried about the coming waves of COVID-19. So we have to be a little cautious with this regards to the immunological phenomena we've been seeing in these patients. Now, the other important concerns in the perioperative period is just not management of a single system. The COVID-19 is finally a multi-organ system, and it affects the long-term effects is also a multi-organ. It can include many, as I just mentioned. Not only this, but the persistence of multi-system inflammatory syndrome and autoimmune conditions, which has been seen in COVID-19, they may get reactivated, or they may they may have impact on the whole body system, and how will they interact in the perioperative period is of a concern. Hence, these patients require again a lot of assessment to look for the residual effect of these conditions. The pulmonary infections in immunocompromised patients, the bleeding and thrombosis are definitely the concerns. And we know that the thrombotic and thromboembolic event in COVID-19, whether they are stroke, whether they are pulmonary embolism, the respiratory concerns, they have been well recorded in these patients with various risk factors. The pathophysiology is already mentioned there, and the clinical outcomes and well be seen in these patients in the form of venous thromboembolism, myocardial infarction, and disseminated intravascular coagulation. And the reasons were many, because of the various risk factors, because of the inflammatory response that leads to endothelial dysfunction. They will lead to these hemostatic abnormalities like pulmonary microthrombi, intravascular coagulopathy, changing in the various biomarkers. And these clinical outcomes has impacted these COVID-19 patients, and hence the recovery from these needs to be assessed in this group of patients. The hypercoagulability and thrombosis definitely remains a risk, but the duration of increases of clotting in recovering COVID-19 patients remains unclear. Many of these patients may be on anticoagulants, oral anticoagulants. So the impact needs to be considered in the perioperative period for this. Also, we need to look for whether there are another risk factors in the recovered patients, the COVID survivors, that how will they interact, for what duration this patient needs to be continued, and whether they are still at risk of increased hypercoagulability needs to be assessed for these patients. And the management still needs to be continued because they're not very sure about it. And multimodal prophylactic approaches for thrombosis and Palliative needs to be continued with these patients in the perioperative period or whatever the interventions we are providing for these. Probably, I think preventive prophylaxis will be a part, just not prophylaxis, but the assessment of these patients would be required because some amount of some clinical thrombotic phenomena can be seen, and hence we should be cautious when we are assessing these patients. Now, this is an interesting study, and they have found the patients who have recovered from COVID-19 as compared to the controls. They found that there were microclots were present in these patients even after a long time, and probably any precipitating factor, even a stress of perioperative period, which is usually a hypercoagulable state, can precipitate thrombosis in this phenomena, and hence we should be cautious. The respiratory concerns, we know that the long-term respiratory complications are quite common. Majority of symptomatic infections have affected the pulmonary system, and the lungs in COVID-19 pneumonia shows damage to alveoli and pulmonary capillaries, which are the two sides of interface where oxygen and carbon dioxide exchange. The potential respiratory problems like chronic cough, fibrotic lung disease, how much from this fibrotic lung disease they will recover. The bronchiectasis and the pulmonary vascular disease probably has been manifested in patients who are COVID survivors. The evidence for these possible sequelae is largely derived from acute manifestations of COVID-19 along with extrapolation from previous outbreaks. But now the follow-up which are coming is confirming these long-term sequelae of the insult that has happened to the respiratory system during the acute COVID-19 infection. And that's why various societies has come up with various protocols looking for these, but probably it appears that the clinical assessment remains important, and based on the clinical finding, the other investigations like chest radiography probably would be required in these patients if they have clinical manifestation to confirm that what type of residual respiratory effect are seen in these patients. A pragmatic approach in these patients, apart from the initial clinical assessment and follow-up, chest radiography and oxygen saturation measurements probably would be an optimal thing, and accordingly we can take care of further management based on the outcome of the initial assessment. Now, coming to the cardiovascular system, the complications that have been seen include the acute MI, the myocarditis, the heart failure, the cardiomyopathies, the arrhythmia, shock and cardiac arrest, as well as strokes, and the venous thrombotic effects. So these are the variable things which could have long-term sequelae. The recovery profile of these patients needs to be looked for, because the heart which was damaged during the COVID-19, the probability of the impairment probably exists in these patients, and hence it mandates the assessment of these patients appropriately. The renal function, there is limited knowledge on pathophysiology of kidney injury, but it appears the interplay of virus-mediated injury, the cytokine storm, the complement pathway activation, the hypercoagulation, along with the pre-existing other comorbidities like diabetes and hypertension in these patients. For those who have survived, the long-term impact still needs to be understood, but yes, some of the issues has been seen in these patients because of the acute COVID-19 and the sequelae. Probably the kidney impairment, but the long-term effect needs to be further studied and reported. Neurological, neuropsychiatric concerns, the strokes, the anosmia, headache, fevers, fatigue, the viral meningitis, the encephalitis, the post-infectious acute disseminated encephalomyelitis, the Guillain-Barré syndrome, myositis, acute necrotizing encephalopathy. Now, many of these patients probably would recover, but some of the residual effect can be seen because of these manifestations, which can increase the risk of future morbidity and mortality in case if they have a stressful event of the perioperative period. And hence it requires a good amount of assessment so that we can look for these stages. The endocrinal changes, the relation between COVID-19 and diabetes, especially type 2 diabetes, is complex. Type 2 diabetes remains a risk factor for serious cases, we all know. But it has been reported that the survivors of COVID-19, the risk of developing type 2 mellitus or worsening of the pre-existing type 2 diabetes has been seen in these patients. And hence probably the occurrence of diabetes probably who has been infected with COVID-19 remains an issue. And hence the diabetic itself will have many concerns in the perioperative period. And hence not only the occurrence of diabetes, but its assessment, its diagnosis and further management needs to be done. Now, this is an important issue of post-intensive care syndrome, where many patients who were admitted to the critical care setup, these patients could have persistent critical illness or chronic critical illness with many bodily changes like poor nutritional issues, endocrinopathies, the impact of infection, the neuromuscular weakness, the cognitive issues, the mood anxieties, and the post-traumatic stress disorders and polyneuropathies. For how long they will recover, how long and how much will they persist needs to be assessed for these patients. Now, having said that, all these features would require, we can easily say that the prehabilitation would be very good, important concern for these patients, so that in the preoperative phase, we can start them on various prehabilitative measures so that these patients can tolerate any surgeries and the outcome becomes better. Not only the prehabilitation, but the rehabilitation also remains an important issue for these patients. The patient preparation probably would recruit the various conventional prehabilitative strategies which are focused for mitigating long-term impact related to COVID-19 and must be included in these patients, starting from various concerns of exercise, medical optimization, the nutrition, the dietary modifications, high protein diet, stress management, and lifestyle choices. Also, we should be careful that the rehabilitation needs to be done for these patients soon after they are recovered, and also in the perioperative period, so that they are from the point of physical and occupational, pulmonary and cardiac rehabilitation, speech and swallowing therapy, so that the overall outcome becomes better, improved, and faster. They can be continued for variable duration depending upon the response, and hence needs to be followed on. So there is still to go on. The COVID-19 risk is still persisting. Cases are still coming. We have to be cautious in perioperative period to take all preventive strategies, whatever possible we need to look for. We need to continuously update our knowledge and skills. We should take care of ourselves also, because it has been a little stressful phase for all of us, and we need to look for ourselves also so that we can take care of our patients much better. We should be having more of a learning, updating procedures, practice, and keep communicating these strategies among us and our team so that we can provide better patient care. Now, COVID-19 has given a good understanding of using the telecommunication, the telehealth, probably telemedicine, and this probably should be integrated into our medical science so that these patients could be rehabilitated, they can be optimized, the home care-based therapies can be given to these patients. So we need to expand access to essential health services for these patients who are COVID survivors and probably would require some type of interventions. So to summarize, as the dust of acute crisis of COVID-19 pandemic settles over months to come, millions of people have already been affected. They are facing the long-term sequelae of COVID-19 infection. Anesthesiologists should recognize these residual effects of COVID-19 disease and provide safe anesthesia. As the timeline for recovery remains nebulous, we must consider post-COVID syndrome like any other medical illness in the patients posted for elective or emergency surgeries, and hence be proficient in managing them so that the patient outcomes becomes much better. Thank you so much.